So thanks very much, Sam. That was excellent. So as always, a really good in-depth knowledge of the topic and also of the data itself. So we have had quite a lot of questions.
Great.
So that's good. So I'll try and go through them in some kind of structure. They are mostly probably headed your way, but I'm sure that Julie Claire can help you if you've got anything. So I'll struggle now, everyone who's listening, to pick up any new questions, but I'll just see whether I can if anything else comes through. So I think we start off, I'll go through it in a kind of timeline. So if we start off with antenatally, got a few things. So it started off with some thanks, which was very nice from Karen Lloyd about the work that everyone put into Precept and seeing that come through. So it's nice to have some good news stories like the increase in magnesium. So that was just a thank you rather than a question. There's a question from Sajid Nezrangadi who said, we would expect steroids and magnesium to go hand in hand in terms of improvement, but it doesn't seem to. Had you noticed that, and do you have any explanation?
I wasn't really expecting, Sajid, that rates of antenatal steroids would go up much further than they already have. Whereas magnesium, it was very clear to me, back from when Bill and I wrote about that in Archives a few years ago, that there was a lot of improvement to occur. And, a lot of things have happened. I suppose it's more than 3 or 4 years ago since we wrote that article. But so I think there's been huge potential for improvement in magnesium. I think there's probably a bit more potential for improvement in magnesium, but I don't think Karen would be upset to hear me say that I'm not convinced that we'll get the national average to 95%, or even much over 90%. But I do think there's a lot of individual patient gain to be accrued by, if you don't know if the woman's going to deliver in the next 10 minutes, getting arrangements made to give her magnesium. I do think there's a real issue, as Julie Claire and many others in the sort of national perinatal team are saying, around the timeliness. And we really think that NNAP, the NNAP measure of antenatal steroids, we think should continue. But we think maternity need to get a measure up and running of timely administration of antenatal steroids, rather than trying to build and extend the neonatal data flow further into the world of maternity. So I expect to see new measures of antenatal steroid timeliness that further help us as a perinatal team, not just us, to do better with respect to steroids.
Okay, thanks. So I suppose you've started to answer the next question that was there, which was, can we control for unavoidable missed targets? So the examples that the person gave were the place of birth for women who just come in and deliver it straight away, or magnesium was the other thing. Somebody comes in. So I suppose you've started to answer that.
So I don't think we can control for it in the analysis. I think we've always got to be sensible clinicians when we look at data about our clinical practice and not be defensive about it. I think there's a strong the woman who comes in delivers, and it's arguable that she couldn't be prevented from delivering in the wrong place, and then there was no time to give her antidepressants, there was no time to give her magnesium. But in fact, in places that I've worked, when we looked back at how the admissions occurred, in fact, that woman's been to and fro and had features of preterm labour. So I think there's a lot in the antenatal optimization toolkit that Julie Claire talked about. Maybe we should ask Julie that we can do to address even apparently cases with apparently inevitable features. We'll never get the rates of antenatal steroids to 100%, in my opinion, and I don't think we'll ever get the rates of magnesium to 100%, in my opinion. But I'm sure there's more we can do, particularly on magnesium. Julie Claire, you probably got a comment on that.
Yeah, I really sympathise with people where women just come in and deliver, but I think when you unpick these and when you really case review them, there are certainly probably around a half where the woman has had symptoms and signs for some time beforehand and she's just not presented early enough. So I think a lot of the work that we're hoping to take forward with BAPAM over the next 12 months is really about improving parental understanding and awareness, perhaps even on a sort of public health campaign scale, to try and get women to labour wards much more quickly. And I think while people talk, they talk about it being unavoidable, I think we just have to be really careful when we say that we have actually explored avoidable factors, such as, you know, and it may be that women have been in and out of hospital. It may be that we've not used an accurate prediction tool to predict preterm labour, and whether or not those could be the solutions for your unit or not.
Yeah, I think that's a really good answer from both of you, actually. And I think that thing about things we call unavoidable, the point of things like peer review or comparison across and within networks, is that what you might think is standard practice could be poor practice or outstanding practice in other places. So that's good. There's another question on magnesium, just while we're on antenatal factors, which was from Nick Bishop. So I probably should ask it, even though I think he's left us. Is that there have been reports of bone disease in babies after receiving magnesium. So is there a maximum dose or a maximum duration that should be recommended for the intervention?
Oh, that's definitely a Julie Claire Becker question. And I understood not. Nick and I have talked about this previously, but Julie Claire, you probably got a more informed answer.
So there is evidence for, or guidance for, the maximum dose that I think is given within NICE, but you can find it in I think it's Appendix 3 of the Antenatal Optimization Toolkit. The dose, the actual dose actually escapes me, but I think it might be something like 3 grams in total.
So sorry, I think Karen's just come on a chat saying she can answer that.
Okay, good.
But I think she can't, because I don't think she's allowed to speak on the way it's set up. So Karen, I think you'll have to type it.
Then that's fine. But again, it comes down to accurate prediction, doesn't it? And trying to get those methodologies really tight so that you know when a woman is going to deliver or not.
I suspect Karen was going to say that that's based on really quite limited case reports from the US, as I remember. But Jess might be able to unmute her. But let's go on to another question and come back.
Okay, so she's put in the chat, it only happens with long courses and very high doses. So I'm taking that to mean that the way it's used in standard practice doesn't cause it. And maybe people could contact Karen to get more detailed answers. So we'll just move on for time, just to try and get a few. There's been a few people have asked about this, so I'll jump to this, which is about feeding. And on the graphs and in the data, there doesn't seem to be a mention for donor milk. So there were 2 ways it was worded. One was when donor milk is included, it counts as mixed feeding, and other people talking about your graph saying donor milk doesn't count. Can you just explain that?
So the graphs that I've shown today are about mother's own milk. And I suspect that we all agree that the objective is for the baby to receive mother's own milk, and that donor milk is a substitute. There are people who think it's a poor substitute. There are people who think it's a good substitute, or a not so poor substitute, but I think everybody would accept it's a substitute. So we're not about trying to measure substitute performance. We're trying to measure what may certainly feel, and in some areas of the country, most of the areas of the country I've worked in professionally, to be honest, it feels quite hard to address. But that's not to say that it's not worth trying. So donor milk's not included in the enumerators in that respect. It clearly has a part to play where mother's own milk isn't available, when no mother's own milk is available. Interestingly, there's a trial proposed about use of mother's own milk to try to encourage women, as part of a package to try to encourage women to use their own milk. But we wouldn't be. I wouldn't be in equipoise about using donor milk instead of formula for certain babies. I think that's not an area of equipoise.
Okay, thanks. And on that topic, since we're talking about feeding and a risk of NEC as well as the other outcomes, there's a question from Lawrence Smile who said, could you check with NNAP leads if they use probiotics and see if there's any correlation with NEC rate variation?
Thanks, Lawrence. That'd be a great registrar project, wouldn't it? We have done that in the past, but not I could almost shout to Lawrence over in Leeds, but that would be a great telephone questionnaire project. In fact, we've got some telephone questionnaire data. So if you want to contact me offline about that, we did a survey a little while ago.
And then I suppose this is sort of related to that in terms of the topic, which is about NEC and its relation to death. So there's some, I think, come from a couple of people, and then also this relates to other measures other than NEC. So you mentioned that NEC, I think, is inversely related to death. Has that been formally analysed, or is that just an association that's noted?
No, it's not been. It's definitely not formally analysed, and it's something that came up as we looked at the data at the key finding stage. One of the thoughts that we had was that we might want to, so you'll have noticed that when we present data on BPD, we don't actually present data on BPD despite what my slide said, it's BPD or death, and that we might want to present NEC alongside a competing outcome of death. So it was really with that in mind. It was a kind of, to some extent, a recommendation to the audit. But thank you. Again, that'd be an interesting thing to look at. We always have to distinguish between research and audit, and that's always a tricky old stuff. But that would be really interesting to look at further, wouldn't it?
Yeah, and I suppose it's linked to another question, which was, which I presume you've given the answer to, but we're interested to see what your thoughts are about mortality versus other measures. So we measure quite a lot of processes like temperature, steroids, but also some outcomes like sepsis. And in terms of are they related to mortality, especially for outliers? And do those measures have any link? Because presumably that's the point of NNAP, is to find things that can improve other outcomes.
Yeah, so I think it's whenever I do any activity, I think it's quite a good idea to remind ourselves what it's for. I think the point of NNAP is to help units and networks, so audit users, I sometimes say, to facilitate quality improvement. The point of NNAP is not to work out whether it's NEC or BPD that causes more death, or NEC or late onset infection that causes more death. There are lots of other epidemiologists to do that. I think so we're not really about that working out where these mechanisms are intersect. For us, the importance of competing outcomes is about providing fair measurement. For NEC, the issue about NEC and mortality, we might need to do both. But we really welcome correspondence about that, and members of the methodology data set group will no doubt, and new members hopefully joining us. Jess, are we still looking for members of the methodology data set group, or is that now closed?
I think that's closed. We've had several people
fantastic
join us.
We'll look forward to that. Oliver.
Yeah, good. So I suppose on that is the question of measures and making sure the measures are right. So we've got a question about the BPD measure, saying that it's a very wide spectrum. So you may be in a trickle of oxygen, or you may be on high frequency ventilation, and you're still in the same group. Has there been any thought to using a different classification like the NICHD and then doing the analysis?
So yes, there's been thought about that, and we've overtly decided not to. There's a clear feeling that oxygen at 36 weeks is the right way to measure BPD in a surveillance context. It clearly encompasses a range of pathologies, from life-threatening bronchopulmonary dysplasia that is going to be life-limiting, through to a pretty trivial oxygen requirement that goes away quite quickly. It's about having something that we can measure reliably. I think there's, NNAP is not the definitive answer to all research questions about BPD, but hopefully some of the data that is collected because we do the work will be useful to others.
Okay. Just on that note, I was hoping someone else was going to ask this question, so rather than pretend they did, this is from me. BPD and mortality are obviously adverse outcomes, whereas giving magnesium steroids, having normothermia are good outcomes, but we still report them in that way around, which means we end up with this strange treatment effect that a positive treatment effect is a bad thing? What are your thoughts on whether we should, given that people are just getting to grips with it, flip those around?
So Oliver, I know you have a strong opinion about this, and there are lots of other people who don't hold that opinion. We had a quite a robust debate, I don't mean you and I, in the group about whether a treatment effect should be expressed positively or negatively. So for those on the call who aren't, so we say that when you're looked after in a neonatal unit, that in effect results in you being more likely to being diagnosed with an adverse outcome, death or BPD in this case, then we say that that's a positive treatment effect, as in that that increases the rate of that outcome. The point that Oliver raises has come up particularly is in presenting these in the spine plots. And if you look at the spine plots on an NNAP online or in the report, they've been flipped around. So all the good outcomes are to one side. I'm particularly interested to get comments from people about the utility or otherwise of the spine plots. When I saw them for NNPA online, National Maternity and Perinatal Audit online, I thought they were a really helpful way of summarizing lots of different audit measures in a single panel. And I found them very persuasive for my own trust and from sort of a presentational perspective. I realize I'm not necessarily the average user. I think we've improved on the NNPA ones, in particular, making them all go in one direction. But I'm keen to get feedback about the use of those. So please do write to me. There is almost only one Sam audit, although there are two on Twitter, but I've blocked the other one. So be pleased to get in touch.
So I suppose that's an important thing to say about NNAP, isn't it? That it's everybody's audit. It's not the audit of a few people, and the program is not of a few people. It's really to try and get all stakeholders to have their say, and where things could be done differently or better, then we really do need to know about that. So do flood Sam's inbox, please.
Can I just quickly take the time to thank some people? So I think that the college have done a brilliant job in terms of building a coalition of people across sort of what you could call stakeholder bodies in a bit of jargon. But I think that's a real strength of the program, that it relates to lots and lots of different bodies who have an interest in neonatal care, and I think that's made the NNAP a much stronger thing. I wanted to thank particularly Jess, who's been the project manager, but also Simon and Duncan, who have Simon and Tom, who have been instrumental in delivering the reports. It's been a great deal of work done and our colleagues at Endow, Kaylee and Nick, who do the heavy data lifting, you could say. So there's a lot of people involved and mostly invisible, but I'm absolutely delighted to answer emails and do that. We do that quite a lot, and it's very stimulating, and most importantly, for your perspective, has resulted in lots of change to the audit. So we do take the feedback seriously, which is not to say that every idea that you come up with is necessarily going to make it to the top of the list. Even Oliver can't achieve that.
Oh, definitely not. And you know, I think it is good. There are discussions, and I'm perfect. You know, there are definitely two views to most of these questions, which is good that we get consensus. There's still a few things to get through. There's a number of people have asked about mortality, treatment effects, and in particular about how deprivation is taken into account. I'm going to just try and summarize a few questions on that just to make sure, and then I might come back to you if I don't think they're all answered. So does treatment effect take into account deprivation, has been asked a few times. Or is it just baby specific things? And then we'll answer that first and then we'll come to this.
Great question, and thank you for raising it. No is the answer to your question. So deprivation is not currently in what you might have regarded as an adjustment model. It's not really an adjustment model, but the listed matching variables. And it had been intended that would occur, and it hasn't occurred. We are uncomfortable about that, regretful about it, and we will put it right. But it won't be this year. We won't be correcting this. Well, it's not incorrect. But we hope to be able to deliver that for the 2020 data report published in 2021.
Okay, so I suppose that's saying there isn't any analysis on deprivation.
That's correct. The list of variables that are in the model has been slightly amended from the matching variables we used last year, and it is published in the report, so you can go away and look at it.
Yeah. And a few people have commented that looking at the net, I think you can see it from the network plots, is that there does seem to be a north-south divide in terms of mortality. Have we got any comment on that?
It's grim up north, as my mother used to say. I don't think we know why there is variation. There is an articulate representative who is on the call of a neonatal network with not so good mortality. And I suppose I'm also a representative, although not articulate one, of a neonatal network with not so good mortality. In general, I think it's true to say that doing some form of case mix adjustment is useful because it makes people believe the data, makes people believe the raw data. The adjustments that case mix adjustment that we've done makes relatively little difference to the take-home message for mortality and actually for BPD. I would encourage us not to get too distracted by measurement effect and to try to think about why it might be. It's not for NNAP to answer the question of why mortality is higher in some places than others. There are, however, I hope, useful recommendations we can make about how people can check for obvious things. And I know of neonatal networks that have gone away and acted already on those recommendations, that are forming evidence-based review groups that are making sure the dissemination of their learning from mortality reviews, those kinds of things.
Okay, good. So these are all quite links actually, but it's slightly different. So BAPM guidance is now available for babies born at 22 weeks gestation. Are there plans for NNAP to change the gestational age for relevant measures such as mortality so that we can have national reporting?
So we already have changed the gestation threshold for antenatal steroids. And if anything, the rate of administration went up. We don't have plans to change the mortality threshold at the moment because even at 23 weeks, the available data suggests that there's a lot of variation in the rates of admitted babies. And so the key thing for us is not to say by excluding certain categories of babies from measurement doesn't mean say we don't value those babies. It's only that we want to concentrate on making sure that we're doing a fair comparison, a fair test, as they say in school science, doing an apples to apples comparison. So for mortality, not thinking of changing the threshold at the moment. It's no doubt a thing we'll keep under review in the methodology data set group.
Okay, there's just a few comments coming through just while we're talking. And a couple useful ones from Karen Lloyd, who said the NCMD report on deprivation looks at effects for perinatal causes of death and also measures mortality at all gestations, suggesting that there is a big effect. I suppose, like you say, there are different reasons that different reports are coming out.
So I think the only I'm not as familiar with the NCMD reporting that Karen's talking about as she is, because she's in charge of it. What I would say is that it's very well known that deprived families are more likely to have a preterm baby. Of course, preterm babies are much more likely to die. It's very well known that on a population level, deprived communities experience more death from prematurity. What's not clear is that a given 23-weeker is more likely to die if his parents are from a deprived background. And in fact, there is some evidence of the reverse. So it's quite complicated and very difficult to get across in this kind of discussion. But I do think we ought to improve deprivation in the model. It was not intentional that didn't happen this year, but I'm not sure it's going to change the message big style.
Okay, we're running out of time. We've just got a couple more questions I'd like to get in. So one is about parental involvement. So, I wouldn't want to miss that one out. And a comment that parents being there on the ward round is a very crude measure. and doesn't really represent parental involvement. Are there any plans to try and to amend that?
So we always welcome well thought out plans to do measurement differently. Prior to Oliver's involvement with NNAP, we worked with parent representatives who suggested the ward round measure. And for all that it is crude, and as I've shown today, I think our analysis of it has been crude, it is nonetheless, it represents an area of improvement that Bliss and our parents were very articulate and persuasive advocates for inclusion of that and measurement of that. And there are definitely neonatal units in the country that just don't believe in having parents on the ward round. And I'm not in a position to argue about that. I think that having parents on the ward round is part of parental partnership, and it's part of a humanity of care that is totally different to when I started in neonatal care 20 years ago. So I'm very enthusiastic about that as a measurement opportunity. Quite how, it's a bit like the parental consultation question. People ask us, well, what was said? What was the content? Who had the conversation? And clearly we could try to measure that stuff, but in a way that is meaningful to compare between units. I'm a little bit skeptical about that, and haven't yet seen a proposal that makes obvious sense to me as to how it could deliver it. But
that wasn't on this occasion, Sam. That wasn't from me. That was
I believe it
from John McIntyre this time. So, but I would have pretended if no one else had asked it. And I suppose so. Suggestions from parents and from users of the system would be very valued, wouldn't they?
Yeah, absolutely.
There's just again on slightly different, I suppose, on data collection, is that as people move to electronic patient records, lots of people are using things like Epic or Cerner. What do you think that's going to do to data collection as there may be moves from Badgernet?
So our position has been that we're going to need to wait and see, and we hope that we'll be able to continue to measure. I hope that the way that we will continue to run an NAP effectively is because people will value it, not because it's in the service specification and people told they've got to do it, not because the neonatal network tells them they've got to do it, but because they can actually find some utility in the results. And I'm hopeful that that will be the case. The key thing from my perspective is not where the data comes from, but that it is useful and that we provide effective reporting. So I'm not so worried about the kind of things that could happen, and we've dealt with challenges in the past, and we'll deal with challenges in the future, no doubt.
Yeah, good. So I suppose it's the thing about making sure it's useful, and then it should be data that people are collecting anyway, wherever they collect it. And I mean, there's one view that as you move to EPRs, it should become easier because there'll be even less duplication. Just, I think I'm just going to try and squeeze one more question in, just because it might be for both of you to answer, which is about away from premature babies and talking about elective cesarean section. The RCOG recommends steroids up until 38+6. NICE don't mention it. And there's some evidence that antenatal steroids may be associated with long-term risks, such as behavioural and mental health issues. Have either of you got any thoughts on that?
I've definitely got thoughts, but I'm sure JC's got much wiser and more intelligent thoughts than I have.
Definitely that is not the case. As I understand, the RCOG guidance is being updated, and I don't think it has been published as yet. So I think the more recent guidance may be different to that, as far as I understand.
My understanding
is we do have obstetricians in the audience, so maybe they could.
Well, while we're unmuting them, can you name one, JC, and Jess might be able to unmute them? My understanding is that the guidance that whoever asked the question is referring to is actually no longer on the RCOG website. And I think there's a lot of concern about giving antenatal steroids at term. And I'm not at all, as yet unconvinced, let's put it that way, that it's the right thing to do. The more mature the baby, the less persuasive the case. The only data suggests that it reduces neonatal unit admission, and not by very much. So I'm unconvinced about that, and I think that's a likely direction of change. Is there an obstetrician who actually knows the answer?
So if an obstetrician can really quickly type that in to their chat, then I can and give some answers. So it was, as you say, it was quite rightly put in the question that it's very old guidance.
Yeah.
But otherwise, I think we're at time. So I think we probably need to wrap up the questions there.
As clinical lead, even though Oliver's officer for audits, I'm going to thank you all for participating and thank you all for your engagement. You've been on the biggest online meeting I've ever participated in, and we're super grateful to you for all your work putting the data in and making clinical change that is improving the lives of babies. And I think there's plenty of evidence that if you look back in our audit over time. So I'm really grateful to you for your engagement. Please do write to the audit or to me. And I'd like to thank the people who organised it, particularly Jess, but many. We'll see you all in the flesh soon in November 2021, albeit hopefully if not before then. So a Zoom wave from me. Bye.